I'm Gregg Stone. I'm an interventional cardiologist and professor of medicine at Columbia University Medical Center and the Cardiovascular Research Foundation in New York City, and I'm here speaking at the VEITH 2018 Symposium. I believe that actually PCI is substantially better than placebo, and we have a wealth of data over many, many years that show that compared to placebo, or compared to control, let's say, in patients with stable coronary disease, that PCI is associated with a substantial reduction in angina, improved quality of life, reduced need to take anti-anginal medications, etc., and improved exercise duration. A lot of this was brought into question, though, because of the sham-controlled ORBITA trial, which did not find a statistically significant difference in exercise duration between PCI and a sham control in 200 randomized patients that were treated for 6 weeks. But this study unfortunately had a lot of limitations. It treated patients with single vessel disease, approximately a third of whom didn't even have ischemia, and they had nearly normal exercise duration to start. So you can't really improve their exercise duration if it's a normal to start. But nonetheless, PCI did relieve ischemia and did lead to a higher percentage of patients that were angina-free, even compared to the sham-controlled, to a very similar extent as to what we've seen in prior unblinded studies, such as COURAGE and the VA ACME trials. We've had many other mechanistic studies that show that placebo effects do not explain all the actions, both pathophysiologically, mechanistically, and clinically, that PCI affords. So the real question is, who should get PCI? And I don't believe we're doing too many PCIs, but in some cases, we're not doing PCI in the right patients. So there are some patients who don't have a substantial amount of ischemia, don't have exercise-induced regional wall motions, who could be managed very well with medical therapy, and they don't need PCI. They should be treated medically. But there are other patients with quite advanced disease, complex disease, that probably are not getting PCI. So I think there is an element of both under-treatment and over-treatment, and with everything that we've learned now about imaging-guided treatment, physiologic assessment to guide which lesions need to undergo PCI, I believe we've been improving steadily over the last 5 to 10 years, and hopefully within the next 5 to 10 years we'll get at the sweet spot where we're treating the right patients with percutaneous coronary intervention.